Hi folks, so this is going to be an overview of hemostasis. It's just a general overview of the topic to give you some structure in your studies so that when you start studying the more specific conditions, you can relate it to where they fit in the grand scheme of things. I will be doing a second talk on some of the specific conditions you're likely to encounter in the emergency department and which are important for your Part 1 exam. So we're going to just have an overview of the coagulation cascade, talk about a couple of the clinical investigations, and just briefly mention disorders of, well, hemostasis in general, not just coagulation. So when we think about hemostasis, there are three aspects to hemostasis, which is the blood vessel, the platelet, and then the coagulation pathway. And we're going to talk very briefly of each of these. So when we think about actual hemostasis, we start with blood vessel wall contraction and then the formation of a platelet plug. Finally, the development of a fibrin plug or fibrin clot, and then eventually, of course, dissolution of that clot through fibrinolysis. So let's start with the blood vessels. So the key actions of blood vessels in hemostasis are reflex vasoconstriction, the reduction of coagulation inhibitors. So bear in mind, in a normal blood vessel that has not been injured, you have to have normal blood flow without the risk of coagulation. So several molecules such as thrombomodulin, nitric oxide, thrombolytic factors, and prostacyclin work to prevent blood clotting in an intact vessel. These have to be reduced if injury occurs and there's a need for clotting, and then also the production of von Willebrand factor, which is a key component in the initial adhesion of platelets to damaged vascular wall. Some of the disorders that might affect hemostasis through abnormal blood vessel function would include connective tissue disorders such as Ehlers-Danlos syndrome, Marfan syndrome, or hereditary hemorrhagic telangiectasia, and vasculitides, probably the most important of which is Henoch-Schönlein purpura. Scurvy, as a nutritional disorder, can also affect collagen cross-linking and lead to bleeding from the gums and petechiae under the skin. So most blood vessel disorders leading to bleeding cause subcutaneous petechiae and bleeding from mucous membranes. Platelet plug formation follows a certain pattern. Endothelial injury then causes release of certain activation factors, as I said, specifically von Willebrand factor, which then leads to platelet adhesion and platelet activation. Platelet activation leads to the release of other factors such as thromboxane A2 and ADP, which then causes the recruitment and activation of more platelets, leading to platelet aggregation and the formation of a platelet plug. This is then interwoven with fibrin and then eventually creates a fibrin clot. So platelet disorders can be quantitative or qualitative. Quantitative disorders or thrombocytopenia can be due to reduced production from bone marrow suppression or increased destruction, as can be seen in ITP or drug-induced immune thrombocytopenia, or consumptive conditions such as DIC and TTP. And some of these conditions we will discuss in more detail in a later talk. You can have qualitative problems with platelet function. Probably the one that we know best is von Willebrand's disease. And we need to know a little bit about certain drugs that inhibit platelet plug formation or platelet function, particularly aspirin, clopidogrel, and the glycoprotein 2B3A inhibitors. This is an overview of the coagulation cascade. I am not going to talk you through this in great detail, but you do need to know it. Bear in mind that you have an intrinsic pathway that is activated by the injury to blood vessels and the release of activation factors, whereas the extrinsic pathway is activated by tissue factor release from injured cells. They both merge in the common pathway to produce thrombin from prothrombin and fibrin from fibrinogen. The stabilization of fibrin clots occurs through the activation of factor 13 to factor 13A. What's missing from here, of course, is the thrombolytic pathway and the production of plasmin from plasminogen. How do we test for coagulation? Well, there are two tests. The activated partial thromboplastin time, which really tests the intrinsic pathway, factors 8, 9, 11, and 12, and then the PT, which tests the extrinsic pathway. This just gives an overview of the sites of action of some common drugs that we need to know about, such as warfarin, the direct oral anticoagulants, dabigatran, apixaban, rivaroxaban, and so forth, and then the heparins, both the low molecular weight heparin such as enoxaparin and unfractionated heparin. You also need to know about the mechanism of action of the thrombolytics, but again, this is not really included in this slide. And this just goes through the two clotting tests that we are accustomed to, the prothrombin time and the APTT. Here are some conditions that may affect the PT and the APTT, and it's good to have an idea of this list, as you need to understand this to interpret the blood results when you get back a PT and an APTT. And again, this is just a short list of some of the things that can cause an elevated PT with a normal APTT, or alternatively, things that cause a isolated prolongation of the APTT. This slide just expands on what we've been talking about to show the thrombolytic pathway, the activation of plasminogen to produce plasmin, which acts on the mature clot to break it down, producing fibrin degradation products and D-dimer. If you have any questions, you can bring them up in class and we'll try to answer them for you. As I said, we're going to have one more lecture which goes into the details of a few of the conditions that we're likely to encounter in the emergency department and which are important for your exam. So we talked about hemostasis in general, including blood vessels, platelets, anticoagulation pathways. I'd like you to use this lecture to help prepare when you are studying the different conditions and drugs that you might need that affect coagulation in more detail. Thank you.